Welcome to all of you. As the Dean of the Faculty of Medicine, I would like to welcome you to the inaugural lecture by Professor, but not just Professor, Distinguished Professor Gregory Lipp. Gregory Lipp is a professor in cardiovascular medicine. He is Doctor of Medicine, Fellow of the Royal College of Physicians, have a diploma in forensic medicine, is a Fellow of the American College of Cardiology, Fellow of the European Society of Cardiology, Fellow of the Heart Rhythm Society, and Professor and Honorary Doctorate recipient at Aalborg University. A warm welcome to Aalborg University, Greg. It's a great honor and a great pleasure for us to have you here. Aalborg University decided a year ago to launch a Distinguished Professor program with the aim of attracting the very best international top researchers to the university. It's a university that is Europe's best and the world's fourth best university in engineering. It's ranked as number 25 on the list of World Young Universities, which is under 50 years. It's number 194 in the world among ranking of all universities. And it is the top 300 in medicine. We believe ourselves it's very impressive for the faculty that's only 8 years old. It is something special to be appointed as a distinguished professor. And it demands something special to be appointed as a distinguished professor. Your CV, Greg, is the most impressive I have ever seen in my long career. You earned your MD from the University of Glasgow in 1988, and today you are Professor of Cardiovascular Medicine at the University of Birmingham in the UK, where you head one of the world's leading research group in the field of thrombosis. But you are on the way to the University of Liverpool, where you will be the David A. Price Evans Chair in Cardiovascular Medicine at the university's Institute of Aging and Chronic Disease. You're also visiting Professor of Hemostasis, Thrombosis and Vascular Science at Aston University in Birmingham in UK. You're visiting Professor of Cardiology at the University of Belgrade in Serbia. Honorary Professor at the Chinese PLA Medical School in Beijing in China. Visiting Professor of Cardiology at the University of Leeds in the UK. Visiting Professor at National Yangming University in Taipei in Taiwan. Wu Chong Visiting Professor at the University of Hong Kong. Visiting Professor at Cleveland Clinic Medical School in Cleveland in the United States of America. Senior Investigator at the National Institute for Health Research in the UK. Consultant Cardiologist at Sandwell and West Birmingham Hospital NHS Trust. So this is really very impressive, and it tells a lot about your way of working and your international network. And then you are, as mentioned, both a professor and an honorary doctorate recipient here at Aalborg University, where you have been affiliated with the Thrombosis Research Group since 2011. You are an absolutely central figure which have been crucial for the group's development, and it's an international leading position in the field of thrombosis research that this group have today, not least because of you, especially with an atrial fibrillation. In addition, you have a significant role in the European Society of Cardiology, a wide range of other responsibilities, such as memberships on various editorial boards, councils, and writing committees for guideline development. With a CV of this caliber, I'm an impressive number of scientific publications, and I must say an exceptional high H index at a level rarely seen. I have never seen one like that. Then there was no doubt we wanted Aalborg University's first distinguished professor to be Professor Gregory Lepp. And fortunately for us, you accepted the honor. You are truly a star on the international research stage. And it is very great pleasure for me to ask you to come up here to the podium together with me so that I may present you with a diploma as Distinguished Professor at Aalborg University. Congratulations, Greg, and I hereby appoint you as first distinguished professor at Aalborg University. Many congratulations.
Thank you.
Flowers. Yeah. Yeah, you take it. I can. Yeah, yes. Perfect. So, yeah.
Okay. And then you just look at me both.
Yeah.
Perfect. Thank you.
Super.
Thank you very much. Thank you.
And hereby, Greg, I will leave the floor to you for the presentation for your inaugural lecture, A Holistic and Integrated Approach to Risk Assessment and the Management of Atrial Fibrillation, easy as ABC. But first, let me just inform you all that we are video recorded during this lecture, so we can send it out to all those, unfortunately, who want to be here but was unable to come today, but really wanted to be here. So, on behalf of Aalborg University, my heartfelt congratulations on your appointment as a distinguished professor, and I think we should give an applause to our distinguished professor, Gregory Lepp. Super. You can handle over to your lovely wife.
Thank you, Lars. I think it's probably fair to say I don't very often get speechless, but I think I'm really touched, and thank you so much for those very kind words. Thank you to everyone here for joining me in this inaugural lecture. I must say it's like being part of a family, and I'm really so pleased to be back here in Aalborg again. And also, just to say thank you for this great honor as your first distinguished professor, and I very much hope I will live up to your expectation, and very much hope that this is only the start of great things together. It has been a great collaboration. As I said, we are family, and it's nice to be able to do research together with friends and colleagues where we are trying to ask questions, do some nice research, and most important, have a bit of fun together as well. And that's, these days, research is without boundaries, and I very much hope this is only the start of even more things, great things together. So, it's a great pleasure to be able to present this inaugural lecture. And as many of friends and colleagues here know, I'm very much a clinician. And I suppose much of what I've been doing in the last few decades in terms of clinical research is to try and make things easy, because I'm a clinical cardiologist and I can't cope with anything more complex. And I like to have simple ways to assess risk. I like simple ways to manage patients. I like simple ways that we can actually improve the outcomes of patients with atrial fibrillation. Atrial fibrillation, of course, has been my research ever since my days as a fellow. That's in the dark ages. I wouldn't say how long exactly, but that's a little while back, and my own thesis was on atrial fibrillation research. But I'd like to take you through some things that we've been interested, particularly in relation to risk assessment, and of course leading up to in terms of practical management of patients with atrial fibrillation. Now, well, first the question, of course, hopefully would be familiar to most in this room, but why atrial fibrillation? Well, I think it's probably fair to say that if you're age over 40 in this room, there's a 1 in 4 lifetime risk of developing atrial fibrillation. And if in this room and you're age over 40 and you're lucky enough in your lifetime not to sustain a heart attack or heart failure, your lifetime risk of developing atrial fibrillation is still 1 in 6. So we're talking about something which is extremely common. Now, atrial fibrillation, of course, is well known because of the increased risk related to stroke and death. And maybe just to put this into context, how serious this problem is on a global basis, is to frame the magnitude of the problem. And let me take you through this, because if you, many of us will remember in 2004, there was a big natural disaster on Boxing Day. This was a tsunami in Aceh province. And those who remember how big this disaster was, there was substantial mortality, morbidity, and disability in that region because of this great natural disaster. Well, if you look at panel A here in terms of the Boxing Day tsunami in the riskiest region of Aceh province within 30 days, you see injured or disabled in the light blue, 10%. You see mortality in the dark blue, 25% within the first 30 days. Well, you can see here stroke-related atrial fibrillation without anticoagulation. You see disabled in pink, 50%. You see mortality, 25% in the first 30 days. This is now stroke-related AF with prior anticoagulation. You see now disabled, 42%, mortality, 9%. And given how common atrial fibrillation is, as I've already mentioned, given how in relation to atrial fibrillation is a global problem, it's not a problem related just to Denmark, it's not a problem related to Europe, it is really an arrhythmia that is a global issue. You can imagine with the risk of stroke and mortality why this is a global atrial fibrillation related stroke tsunami if we do nothing about it. So the first step in terms of trying to make things easy for management is risk assessment. And there's lots of risk factors associated with stroke and atrial fibrillation. The list is pretty long, but the more common and the more validated stroke risk factors have been put into risk scoring schemes. And the one used in most guidelines these days is now the CHA2DS2-VASc score. Now, the CHA2DS2-VASc score was not designed to include every conceivable stroke risk factor. It was meant to basically include the more common and the more validated ones. And remember, this is a risk score that we've been put together to help clinical and practical decision making for you and I in a busy ward, in a busy clinic, how to assess stroke risk in patients with atrial fibrillation. And you'll see that this is a difference from the older CHA2DS2 score. For example, age 65 to 74 gets 1 point, 75 and above gets 2 points because age is a very powerful driver of stroke risk. We have, for example, vascular disease, and depending on what the data available from when this was derived, it was prior myocardial infarction and peripheral artery disease. But then again, remember, this is a simplification of to help decision making. And just to illustrate what I mean by simplification, it's meant to be a score that is reductionist. Because you see, age 65 to 74 gets 1 point. It doesn't mean your patient's 74 years old in 11 months to get 1 point. 4 weeks later to come back to your clinic, they become 75, they get 2 points, and suddenly their risk doubles. It doesn't work like this. And it's only common sense that somebody who is age 75 is going to be lower risk of stroke with somebody who's age 85, or for that matter, 95. So risk scores such as CHA2DS2-VASc are simplifications. And you'll see in some guidelines that they use the CHA2DS2-VASc score and they divide patients into low risk and moderate risk and high risk, which of course is artificial. And those of us here looking after patients, how many of our patients fall into 3 little neat categories? It's almost like trying to divide them into 3 little neat categories, and patients don't behave like this. So you're almost doubling the potential for error. The CHA2DS2-VASc is already a simplification, and using the CHA2DS2-VASc to subdivide into low and moderate and high is another simplification of a simplification. So you can imagine how this adds to difference in error. But can I illustrate to you some reasons why risk scoring systems like the CHA2DS2-VASc score, in a sense, were designed to be pragmatic and simplified? And take, for example, female sex as a risk factor. And this is often asked, why do we have the SC criterion within the CHA2DS2-VASc score? Because we recognize there is, overall, female patients with atrial fibrillation are higher risk of stroke compared to men. And as you can see in this systematic review and meta-analysis that we publish, in terms of stroke, you see females, 24% higher risk compared to males. But in terms of the other endpoints like thromboembolism, bleeding, cardiovascular death, and all-cause death, this is not statistically significant. But what has been pretty clear, and I think it's fair to say is data, including that from Aalborg, have looked at this, because there's an age dependency to this, because females age under 65, without any other stroke risk factors, there's no excess of risk. So in other words, females more than 65, or if there's another stroke risk factor present, then it is additive to the risk. Hence the concept, female sex, or the Esc criterion in the CHA2DS2-VASc is a stroke risk modifier rather than a risk factor per se. And that is illustrated nicely here. Look at these top two graphs here, because for the simplification, let's look at the outcomes at 5 years. Blue for the boys and red for the girls. As you can see, when you got basically 0 or maybe 1 risk factor, there's hardly any difference. But once you get 1 extra risk factor and beyond, you see how the curves start to diverge. So in other words, if you ignore the Esc criterion in the CHA2DS2-VASc and you're talking to patients about their potential risk of stroke, you could really be underestimating what their risk of stroke is if you ignore the female sex criterion. So female sex is a risk modifier within the CHA2DS2-VASc. And that is reflected within some of the guidelines. I said in the CHA2DS2-VASc, age 65 to 74 gets 1 point, 75 and above gets 2 points. Now, that is, of course, based on some of the epidemiological criteria or epidemiological data from largely Western populations. Is it actually 65? Well, I don't think that's necessarily the case internationally or globally. And as already emphasizing the point, it is a simplification. And you will see here, these are data from Korea, and there are similar data also from Taiwan. You see that risk of strokes, ischemic stroke, starts to rise from age 50 to 55 upwards. So even if you look at patients, male patients age 50 to 64, who would conventionally get a score of 0 on the CHA2DS2-VASc, and therefore we would normally call these patients low risk. In Asia, that the ischemic stroke rate untreated is about 1.5% per year. And 1.5% per year untreated for ischemic stroke, that's a real risk, bearing in mind that strokes related to atrial fibrillation are more likely to be fatal, more likely to be disabling. And you can imagine the scenario, somebody who's aged 60 years old, male patient, conventionally would be considered as low risk, therefore not an anticoagulation. If their ischemic stroke rate is in the region of 1.5% or so, they could be affected by a devastating and disabling stroke. And these patients would normally be breadwinners for their family in Asia. So in Asia, you might see that the age threshold may actually be lower. And this, of course, the reasons why are subject of ongoing work to explore. Let's talk about blood pressure, because the H in the CHA2DS2-VASc refers to hypertension, and conventionally refers to history of hypertension or uncontrolled blood pressure. So the next question, therefore, is, well, what sort of blood pressure should we aim for in a patient with atrial fibrillation? And let's say you had a young patient, maybe the hypothetical 50-year-old man with atrial fibrillation, with a history of hypertension who's well controlled. Are they still at excess of risk? Well, we tried to address this. We looked at these are from the Korean national registries, but more importantly, in Korea, they also have two yearly health checks. So we almost have a mini Framingham for the whole Korean nation. And we therefore looked to, in terms of blood pressure, firstly tried to answer what is the optimal blood pressure control or blood pressure target in atrial fibrillation patients with hypertension. And as you can see from this publication, which was just out a couple of months ago, looking at major cardiovascular events, looking at death, looking at ischemic stroke or intracranial bleed, myocardial infarction or heart failure admission, you see the nadir, where you get the lowest event rate, is when the blood pressure is 120 to 129 systolic and less than 80 diastolic. That's when you see the outcomes are the best for patients with atrial fibrillation. Now, if you do look to the 2018 European Guidelines on Hypertension, and you look for the table which looks at manifestations of hypertension target organ damage. You'll see atrial fibrillation is listed amongst the manifestations of hypertension target organ damage. And that's quite relevant because in general, blood pressure targets have been, of course, subject to a lot of controversy this year with the US guidelines and now the European guidelines, which is really the best target to go for. But in Europe, we are more pragmatic and probably right. Because we say for majority of patients, we should be aiming for under 140/85. If you've got evidence of target organ damage, and for many of us who look after hypertension patients, we tend to think whether it's proteinuria or whether it's evidence of left ventricular hypertrophy on an ECG or echo, we should be aiming for nearer 130/80. If you list atrial fibrillation as a manifestation of hypertension target organ damage, there's no big surprise. Actually, if you aim towards 130/80 or preferably under, you get the best outcomes, and that's what we have shown in this particular study. It's probably worth highlighting a little anecdote from my early days as a junior, because junior consultant, I used to run the atrial fibrillation clinic, and my mentor, who's now retired, Gareth Beavers, used to run the hypertension clinic next door, and I used to refer to Gareth, said that he was running the pre-AF clinic, and that's probably right. And just to say how these curveballs happen, because I now have to run the hypertension clinic. So I'm running the pre-AF clinic and I'm running the AF clinic in my everyday practice at the moment. Now, back to this point about history of hypertension alone. This was also looked at in this particular publication, and as you can see, you almost see this nice gradation between non-hypertensive, what is conventionally regarded as well-controlled hypertension, and of course increasing levels of hypertension, where you will see in terms of the hazard ratios there, as you can see, this nice graded response. So back to the original question, does somebody who's age under 65, who has a history of hypertension, reasonably well controlled, does that score 1 point on the CHA2DS2-VASc score? The answer is yes, because these patients are higher risk of stroke. Secondly, what is well-controlled hypertension today isn't necessarily well-controlled hypertension next week or next month or 6 months down the line, because of course patients, they very often don't do what you tell them to, and they don't take their drugs, or they run out their tablets, they become uncontrolled hypertension, and that's when the risk goes up substantially. Now, I made a point about the CHA2DS2-VASc score, including the more common and the more validated stroke risk factors. And it's not every stroke risk factor is in there. And of course, just to give you an example, hypertrophic cardiomyopathy is not that common. But then again, we have recognized an increased risk of stroke in hypertrophic cardiomyopathy, especially if there's atrial fibrillation present. But then again, you can say, why isn't the CHA2DS2-VASc score include hypertrophic cardiomyopathy? You could make a case that the hypertrophic cardiomyopathy is included within the C criterion, because hypertrophic cardiomyopathy is the classic example of heart failure preserved ejection fraction. So if they've had hypertrophic cardiomyopathy and had obviously a presentation to hospital practice, they're obviously bad enough, and therefore you could score 1 point by the C criterion of the CHA2DS2-VASc score. But I think it's a bit more than that, because this is such a high-risk group of patients, because you'll see here that in terms of their risk, even though the HOCM or hypertrophic cardiomyopathy patients who are categorized as low risk by the CHA2DS2-VASc score, their ischemic stroke rate is still in the region of 3 to 4% if you leave them untreated. Another example of simplification, because even though you'd give HOCM patients 1 point by the C criterion of the CHA2DS2-VASc score, look at the event rate, 3 to 4% per year untreated. That's well like a CHA2DS2-VASc score conventionally of about 3 or 4 points. So these patients are very high risk. Another example, the V criterion in the CHA2DS2-VASc score, that's, and as I mentioned on the earlier slide, that refers to myocardial infarction or the presence of peripheral artery disease, or if imaging's been done, the presence of complex aortic plaque. So the question then remains, those who undertake cardiac catheterization here, they see significant coronary disease. Is that relevant? Is that not relevant? Well, these are with colleagues from Aarhus, and this was looking at the severity or extent of coronary artery disease at cardiac catheterization. Overall, there's about a 25% increase in the risk of ischemic stroke. This is adjusted by the presence of coronary artery disease, but as the slide nicely shows, in terms of ischemic stroke, the numbers of vessels diseased did not make a significant difference. So it's really basically saying that if there's presence of atherosclerotic vascular disease, symptomatic or asymptomatic, even detected at coronary angiography, these patients are higher risk of ischemic stroke. And I think that's relevant. It reflects the fact that vascular disease is a systemic phenomenon. And this is one argument I often give to the enthusiasts for left atrial appendage occlusion to prevent ischemic stroke. I always tell them, well, if you're so convinced it's the left atrial appendage that is the cause of all the problems, explain to me why one of the most powerful drivers of ischemic stroke in patients with atrial fibrillation is the presence of complex aortic plaque on the descending aorta. So think about this, ischemic stroke. But one of the powerful risk factors for ischemic stroke is complex plaque on the descending aorta. And this is reflecting a systemic vascular pathology that is leading to this excess of ischemic stroke risk. So we talked a lot about risk factors and how they lead to ischemic stroke. But let's just take a step back, and apologies if I upset any epidemiologists in the audience, because what happens with looking at risk factors or these multitude of studies you're seeing are looking at biomarkers. They measure something at a baseline visit, and they look at the outcomes maybe 5 years later, maybe 10 years later. And can you see what's happening in the 5 years and the 10 years? Patients get older. Patients develop incident risk factors. So we explored this. This is using the Taiwan registries now. And we looked at baseline CHA2DS2-VASc score. We look at the follow-up last recorded CHA2DS2-VASc score. We look at the change in the CHA2DS2-VASc score, and for brevity, I'll call that the delta CHA2DS2-VASc. I'm not proposing a new score. I'm just saying that we're looking at the change in the risk factor profile. Well, look here at the pie charts here. With ischemic stroke, you see the majority who present with an ischemic stroke, the majority had a change in their CHA2DS2-VASc risk factors. Of those without an ischemic stroke, you see a sizable chunk there showed no change in their CHA2DS2-VASc risk factors. And that's reflected by these ROC curves here. These are receiver operator characteristic curves in terms of prediction, and here's the C indexes here, as you can see. You see the best prediction in terms of the C index there is actually for the delta CHA2DS2-VASc. The take-home message from this, we assess risk. Risk is a dynamic process. Risk is not a one-off process. Like these folks obsessed with biomarkers try to use for risk stratification. Risk is something that we need to do at every patient contact. So practical tip, you see a patient in clinic, you reassess risk at every time. And that's, of course, it's nice to try and replicate the data in different populations independently. So we looked at this also in the Korean national registries as well, see the same thing. You will see here those categorized as low risk who stay low, they are very low risk. But once they transition from low to again, artificially, to intermediate or to high risk, you see how the risk of ischemic stroke goes up correspondingly. You see this in the intermediate to intermediate to high as well. So the patients do not remain static in terms of their risk. Stroke risk in atrial fibrillation is a dynamic process, and risk assessment needs to be done at every patient contact. But we're talking about an arrhythmia that does not just static in terms or dynamic in terms of their clinical risk factors. Even the arrhythmia itself plays a part in this. These are data from the Fushimi Atrial Fibrillation Registry, and we were looking at outcomes in the progression from paroxysmal to sustained atrial fibrillation. And here are the outcomes in blue, ischemic stroke, in gray, all-cause mortality, in orange, major bleeding, and in yellow, hospitalizations. And that's for the overall cohort year, event rates per 100 person years. Now, that's the pre-progression period, that's the peri-progression period, the post-progression period. And you'll see in terms of the highest event rates is during the peri-progression period. We're dealing with an arrhythmia. Not only does risk dynamic, the arrhythmia itself is dynamic. So the fact that arrhythmia progresses from paroxysmal to sustained atrial fibrillation leads to more outcomes in the peri-progression period as well. So we're dealing with a condition that is certainly, when it turns to risk assessment, is not a static one-off thing. It is a dynamic process. Now, CHA2DS2-VASc is a clinical score, and one of the nice things is that it's been validated now in numerous populations, different ethnic groups. This is one example from last year from the Korean database. You'll see here, as with also from data from Danish registries and elsewhere, with the increasing CHA2DS2-VASc score, look at the ischemic stroke rate for the atrial fibrillation patients in orange, going up very nicely. But as you will see here, also consistent with data we've published from Aalborg, that in the non-AF population that's in the green, you see as the CHA2DS2-VASc score goes up, the risk of ischemic stroke goes up as well. Now, that shouldn't come as any big surprise at all. After all, what is the CHA2DS2-VASc score? It's a collection of the common risk factors for stroke. And the fact that it predicts ischemic stroke even in the non-AFib population, that should not be any big surprise at all. Now, CHA2DS2-VASc, as I mentioned, is a clinical score, and whether you look at AF scores like CHA2DS2-VASc or CHADS or HAS-BLED or even non-AF scores, TIMI or whatever, all these clinical scores, they don't identify the high-risk patients that sustain events very well. So if you're looking at the statistical measure, the C-index, they generally run around 0.6. The difference with the CHA2DS2-VASc score shown here, you categorize somebody as low risk by the CHA2DS2-VASc score, in other words, 0 in males or 1 in females. Rather consistently, the event rate is about 1% or under, 1% being the threshold for treatment. And you see here in this Korean data, you see how the ischemic stroke rate in the AF population in orange is well under 1% and almost no difference from the non-AF population. So the CHA2DS2-VASc score identifies the low-risk patients very well. But in terms of beyond the low-risk patients, even a single risk factor confers risk. And we've published this from Aalborg, and in a sense, I'm deliberately not necessarily just showing all the data we've published, because you all should know this. So I'm trying to show how the Aalborg data has also been consistently shown in other independent populations. So this is from the Taiwan registries, looking at patients with a single stroke risk factor. So it's a CHA2DS2-VASc score 1 in males or 2 in females. You'll see in males, ischemic stroke rate 2.7% per year untreated. In females, 2.6% per year untreated. But if you're distilling this down to a single stroke risk factor, it shouldn't come as any big surprise at all that not all the risk factors will carry equal weight. And as you will see here, the most powerful driver is age 65 to 74 getting 1 point. You see 3.5% per year ischemic stroke rate. And of course, that is another simplification, because I've already mentioned before, somebody who's maybe age 65 is going to be lower risk than somebody who's age 74. Again, just common sense. Here we have diabetes, then followed by heart failure, hypertension, and vascular disease. And you see the same pattern in patients, in female patients as well. So, bottom line, is it worth putting such patients at risk by not giving them stroke prevention? Because 2.6, 2.7% per year, given that AF patients with strokes, they're more, the fatality and the disability associated with AF-related strokes. You really cannot do the mirror test. You can't look at yourself in the mirror and just forgive yourself for not treating these patients and offering them stroke prevention. But in terms of keeping life simple and practical, just to flag up the points I made, and this was also highlighted in a recent systematic review. This is the US government commission PCORI review. Just because it's US government commission doesn't mean it's right, but anyway, just to say that this is a national systematic review published, and it does make some of the points I've made. Risk scores are simplifications. They help decision making. All the risk scores have modest predictive value for identifying the high-risk patients, and this systematic review identified the CHAD score, the CHAD-VAS score, and the ABC score, which is a score based on biomarkers, as being the best three scores for identifying the high-risk patients. Complicated risk scores and the biomarker-related scores, they only marginally improve on prediction. And I've made the point, risk is dynamic and not a static process, and stroke risk should focus on risk factors rather than artificial categorization into low, moderate, and high. So back to you in the outpatient clinic. Rather than get obsessed with identifying low risk and moderate risk and high risk, rather than get obsessed with the high risk end of the spectrum, we should change our thinking. We should focus on the low risk patients first, because why? CHADS-VAS identifies the low risk patients very well. I've already showed the data that even beyond with a single stroke risk factor, it confers a risk. And there's other data that I haven't shown that the net clinical benefit is already positive even with a single stroke risk factor. So step one, is your patient low risk? CHADS-VAS score 0 in males, 1 in females. If yes, no antithrombotic therapy. Step 2 is to offer stroke prevention to 1 or more stroke risk factors. Stroke prevention means oral anticoagulation. You deliver that either as a vitamin K antagonist like warfarin, but paying attention to the time in therapeutic range, or the TTR, above 70%. And these days we're in the era of the NOACs, the non-vitamin K antagonist oral anticoagulants. We're giving anticoagulants, we pay attention to bleeding risk. I'll come back to that a little bit later in my presentation. So this is how you simplify the approach to stroke risk, the decision making. And of course, that has moved on to guidelines, because these are the most recent of the international guidelines, referred to as the Esc Guidelines or the ACCP guidelines. And as you can see, rather than following some of the other US guidelines on low and moderate and high, it's got this stepwise approach. Step 1 is identify the low-risk patients, no antithrombotic therapy. Step 2 is stroke prevention with anticoagulation, assess bleeding, and recommends the HESBLED score. Step 3 is you make your choice of anticoagulants, and like most international guidelines, the NOACs are recommended as first-line therapy for oral anticoagulant therapy. But having said that, it recognizes also that vitamin K antagonists are very widely used worldwide. And even in US, bear in mind that many patients have to pay for it, for their drugs. Some of them cannot afford a NOAC. So warfarin is still quite well used even in countries such as the USA. And it says if you're considering vitamin K antagonists, you calculate the same TTR score. And what is this? Why use the same TTR score? I'll explain this in a second. Because like a clinical score, you use it to flag up the patients who, on probability, are not going to do so well on warfarin. Therefore, you can make a choice on their management decision. Let me explain what I mean. Warfarin has been around and is a great drug. It's been around for a good 5 or 6 decades. And warfarin these days we recognize is not simply writing a prescription for warfarin and forgetting about it. As this slide very nicely shows, if the TTR, time in therapeutic range, is 70%, 80%, you see the strokes and the bleeds are very low. If the TTR is 40, 50%, you see how the strokes and the bleeds are very high. So you have to pay attention to the quality of anticoagulant control. But the challenge is how you identify these patients who are going to do well on warfarin with a good TTR. Because warfarin is influenced by so many clinical factors, drugs, genetic factors, and everything else. So it's really how you can identify those patients. And this was a problem posed to me by our local general practitioners, because our general practitioners were coming to me and said, look, we are signed up to the NOACs, but look, we can't prescribe to 100% of our population because it'll completely blow the drug budget. But having said that, we can manage warfarin quite well in the patients who are going to do well on warfarin. And so this was a challenge posed to me and my group. We derived, therefore, the same TTR score. This is a score using some of the common factors influencing warfarin in everyday practice. The acronym is defined here. Female sex gets 1 point, age under 60 gets 1 point, 2 comorbidities gets 1 point, interacting drugs get 1 point, smoking 2 points, non-Caucasian race gets 2 points. This is the original derivation, but subsequent derivations have shown basically that if you have a same TTR score above 2, on probability they're not going to do so well on warfarin. Therefore, you need extra measures. You bring them back for more regular INR checks, or you can maybe not bother about that and then just put them straight onto a NOAC. And we've looked at this in different cohorts now. There's a bit of consistency. Let me share this recent one with you. This is from a Spanish registry. And as you can see, same TTR score, 0 to 2 versus above 2. You see how nicely it manages to dichotomize the patients who are going to do well on warfarin with a good TTR. If the score is 0 to 2, or if it's above 2, it's going to be less likely to do well on warfarin. But more importantly, it also translates to the bad effects related to poor anticoagulant control. And as you can see, if the TTR is good, the event rates are low. If the TTR is poor, how the event rates are also higher. So not only does the same TTR score predict the patient is going to do well on warfarin or not, it's also going to predict downstream the bad effects if the warfarin isn't well managed. Now, warfarin, of course, like stroke risk, is a dynamic process. It doesn't mean you do a one-off assessment of TTR and the INRs, the patient remains the same. This was done in an Italian cohort, and let me take you through this. This is how the study is designed. Group 0 are those who have maintained a good quality anticoagulant control over the time of follow-up. Group 1 start good control and then they get worse. Group 2 are those who start badly and then they get improved their TTR. And group 3 are the no-hopers. All of them just have a poor anticoagulant control. And look here at the hazard ratios here. You will see that basically group 1, which is the ones who are deteriorating, or group 3 are those who are consistently with poor anticoagulant control. They are the ones who sustain the most adverse outcomes. So even not only stroke risk, not only the arrhythmia changes, not only that risk changes, even parameters like trying to control with warfarin will change in these patients. So let's talk about the impact on a wider scale, because there are data now published from different countries in the world, Denmark included, and just to show another set of data with regard to how the NOACs have changed prescribing and the impact on outcomes. Now these are from Taiwan, and you see between here 2008 and 2015 how the anticoagulation rates have risen considerably. And remember, this is starting from a low base. You see in 2008 anticoagulation rates are about 15% of the Taiwan population. And you see now in 2015 it's gone up substantially, but you could arguably say whether it's driven by the introduction of the NOACs. But the important message from this slide is, look here in relation to the outcomes for stroke, which is the little red dots, and for mortality, which is the little blue dots, how these are coming down very nicely over this 15-year period. So on a population basis, and if you focus on the health economy or the healthcare system impact of the introduction of an intervention like stroke prevention, how it reduces stroke, how it reduces mortality. And in terms of serious bleeding, like intracranial bleeding, remaining reasonably constant over this time. But of course, we've seen this in the Danish data. This is, you will see here, look at this slide here. Following the introduction of the NOACs, you see warfarin prescribing, that's the little pink line there coming down consistently, following initially with dabigatran, which plateaued, then declined. Then here's rivaroxaban in yellow, and in orange, apixaban. So as the NOACs started coming back down, you see the new starters in terms of warfarin prescribing coming down very nicely over this time. But of course, this has led to guideline changing publications. Here's one from Aalborg, led by Peter and the team from the thrombosis research group, looking at NOACs in patients with atrial fibrillation and the outcomes compared to warfarin. This was published in the BMJ. We have here basically data now for all the NOACs. This is now looking at the latest NOAC, which is edoxaban, a factor Xa inhibitor. And in the US, they've got large claims data sets, and this came out last week. This was in a data set of 285,000 patients on anticoagulation, new starters, and looking at the outcomes of the different NOACs versus warfarin. So virtually every journal, cardiology, hematology, thrombosis, we now have the data on how NOACs are performing in everyday practice. So let's turn from stroke prevention to bleeding risk. And it's worth highlighting, taking a step back, highlighting why. And let's take a step back, not just in atrial fibrillation patients. You start a patient on antithrombotic treatment. Why do you want to do that? Because you would, as part of good clinical practice, you would assess their risk of bleeding by starting an antithrombotic. Because we're talking about risk in a patient. You want to assess the patient for reversible bleeding risk factors, and that includes things like uncontrolled blood pressure, labile INRs if it's a warfarin patient, concomitant use of non-steroidals, and of course the alcohol boozers, the alcohol excess patients. You want to think about that and address those. You want to identify, the next step is you want to identify the patient at risk of bleeding, so you like to bring them back for review. You want to bring them back. A high-risk patient, you want to bring them back in 4 weeks. You don't want to bring them back in 4 months or 6 months or 12 months, because that's why you use a clinical score. You pick out the patient at risk, that you bring them back early rather than later. Because particularly we're now in the era of electronic health records and electronic alerts, because you categorize somebody as low risk usually means no action. But you categorize somebody as high risk, you switch on a computer in the morning, this red box comes up, bring this patient back for early review. That's why you do these sort of clinical scores like this. And if you look at the Esc Guidelines from 2016, there's this table. Because it tells you to look at the risk factors for bleeding. It doesn't tell you to use any particular bleeding risk score. It tells you to look at the risk factors, the modifiable bleeding risk factors. There's the so-called non-modifiable bleeding risk factors, the things you and I cannot change. But importantly, the guideline writers had forgotten that these things here interact with this column here. And there's also this biomarker bleeding risk factors, things like troponin, like renal function. There's this thing called GDF15, which is a biomarker proposed as a as a biomarker for bleeding. So to all intents and purposes, that's what we can concentrate on or modify as modifiable bleeding risk factors. Now, a bleeding risk score has been around for a while. This is the HAS-BLED score. And the acronym is shown there. In interest of time, I'm not going to read every line there. But if the HAS-BLED score is 3 and above, you see the patients are at significant risk of bleeding, that you may wish to flag these patients up to bring them early back for review rather than late. But of course, importantly, highlighted in blue now are the modifiable bleeding risk factors that I showed on the ESC table. So the HAS-BLED score not only addresses or flags up the modifiable bleeding risk factors, it is now also a score to bring the patients at risk of bleeding that you want to review earlier rather than later. What about the biomarker bleeding risk scores? Well, there's one which deserves special mention, because the one is the ABC bleeding score, and this was basically simple because it's A for age, B for bleeding, and B for biomarkers, and including GDF15 and renal function. And of course, it's derived in a selected clinical trial cohort, and they were all anticoagulated. But when you actually translate this to the real world, and we did this in the Spanish anticoagulation clinic, it doesn't work. It doesn't show any advantage of a complex score with biomarkers over traditional, good old clinical risk factor-based scores in the long term. And more importantly, if you look at biomarker type studies, and believe me, this is from somebody who spent 15 years of his early research trying to chase biomarkers to predict high-risk patients or not, you will see here protein, but this is from the large epidemiological cohort from pooled analysis there, biomarkers of cardiovascular disease and mortality. Top of the list, GDF15, predicting atherosclerotic cardiovascular disease, heart failure, mortality, and death. You'll see here GDF predicting outcomes in heart failure. GDF is actually a good marker of glaucoma progression. So basically, with many biomarkers, and GDF is no exception, is predicting a sick patient or a sick heart specifically. So we're talking about non-specific biomarkers here that are reflective of a sick patient rather than specifically the fact that they're higher risk of stroke or higher risk of bleeding. So the only way to try and persuade in terms of clinical practice is to compare them. So we did this. We compared the Hasbled score to other clinical scores like atria, orbit, hemorrhages. We also compared against the European score based on modifiable bleeding risk factors, as mentioned. And as you will see here, in terms of the C index for prediction, the best prediction was the Hasbled score for major bleeding and for intracranial bleeding. And this European Society of Cardiology proposal to focus on modifiable bleeding risk factors, it didn't even predict extracranial bleeding, non-significant. So, conclusion, if you simply rely on bleeding risk assessment with modifiable bleeding risk factors, it is an inferior strategy for predicting patients at high risk for major bleeds, intracranial bleeds, or extracranial bleeds. So, other message is guideline writers don't always get it right. And in fact, the PCORI systematic review, I showed this screenshot earlier. What are the points it makes? It actually makes, in the conclusion, Hasbled provides the best prediction for bleeding risk. Yeah, okay. And it also makes the point, bleeding risk is to address the modifiable bleeding risk factors. It flags up the patients for review. Bleeding risk is highly dynamic. I'll say a word about that. A high bleeding risk score is not an excuse to withhold anticoagulant therapy. And really, this is an education and implementation issue. It's not, guidelines are to give the best evidence and the best practical advice. Education and implementation, that's a different story. That is what people need to understand how to use scores appropriately. The CHEST guidelines, in contrast to some other guidelines which are evidence-based guidelines, the CHEST guidelines are evidence-based because they use the GRADE methodology. After reviewing the evidence, it does say bleeding risk assessment at every patient contact, focus on the modifiable bleeding risk factors. It does say use the Hasbled score. It does say the high-risk patients, Hasbled score 3 and above, warranted more frequent review and more early follow-up. But like stroke, bleeding risk is also very dynamic. And we have looked at this. This is looking at incident bleeding risk factors. Again, same design as what I mentioned before. We look at the baseline Hasbled, we look at the follow-up Hasbled, we look at the change in the Hasbled score. And in fact, perhaps arguably the best prediction was actually for the follow-up and the delta Hasbled, the change in their bleeding risk profile. But there is another important message from this slide. If you see somebody with a change in their bleeding risk profile, the danger period is the first 3 months. It gives an added justification of why I said to use the Hasbled score appropriately. You flag up the patient to bring them back early for review rather than follow-up. So let's bring this all together because I've given lots of data. I've explained about how some of these scores can be used, assessing stroke, assessing bleeding, and assessing your choice of anticoagulants. But we're managing AF patients as a whole. We're not managing a bit of the patient, we're managing the whole patient. So we talk a lot about stroke prevention, and perhaps quite rightly so, because that really is top of the priority list. But we're managing the patient, and much of the management of patients with atrial fibrillation is focused on symptoms, and it brings into the discussion about rate control and rhythm control for patients with atrial fibrillation. And remember, our patients with AF are very often elderly and have multiple risk factors, so it's looking also at the associated risk factors and comorbidities, and therefore this is put together into a patient pathway, how you manage patients in an integrated manner, in a holistic manner. And why is that relevant? Remember that AF increases the risk of stroke. That's what we've been talking about. We tend to forget atrial fibrillation independently increases all-cause mortality. But if you look at the mortality in atrial fibrillation, only 1 in 10 of the mortality is stroke. 7 out of the 10 of the mortality in atrial fibrillation is cardiovascular. And if you're trying to manage the whole patient, sure, we should focus on the stroke prevention. We have to focus on the whole patients and manage the cardiovascular comorbidities as well. This brings in the concept of so-called integrated care. Integrated care means different things to different people, and the studies that have been done so far, as you can see, are relatively modest in size. Some are nurse-led interventions, some are educational interventions, some, again, are sort of trying to put patients into a streamlined pathway. But even despite the limited evidence, you will see There is a significant benefit on mortality, about 40-50% here. For cardiovascular hospitalization, in this meta-analysis, you will see here about a 40% advantage of integrated care intervention rather than not. So, 2016 Esc Guidelines, there's this nice figure here. It's the so-called domains of atrial fibrillation management. It talks about rate control, rhythm control, precipitating factors and lifestyle changes, assessing stroke risk, rate control and assessing heart rate, assessing the symptoms and managing this. Some of these lead to improved life expectancy, some of these lead to better quality of life. And then in a rather long paragraph, it comes to this statement, it concludes with this statement: we need integrated care of patients with atrial fibrillation to improve life expectancy, quality of life, autonomy, social functioning. We require an AF heart team. But it doesn't actually tell you how to deliver it. So you can read the whole paragraph multiple times. I have, other colleagues and collaborators have, and then it boils down, how are you going to deliver this? You can deliver this in a rather complex manner. The top here is the current silo working of managing AF. That's the GPs, that's the outpatients, that's the neurologists, that's the emergency room, that's the cardiologist, that's the general medicine. But it shouldn't be like this. And in fact, this was a few years ago, working with some of our local primary care doctors. This was one of the things they highlighted. They said in general practitioners were saying to me, you guys in the hospital, you manage AF different from how we do it. My colleagues in the hospital, non-cardiologists, were saying, well, we non-cardiologists manage AF different from how you cardiologists manage AF. And even within the cardiology department, my non-AF colleagues were saying to me, you in the AF clinic, you manage AF different from how we do it. And that's just wrong. We should be managing AF in a simple, holistic manner that is simple across the whole way. Even the patient coming to the clinic should understand the principles of managing atrial fibrillation. Now, that's a tall order. How can you really make it so simple? How can you actually streamline the fact that GPs, non-cardiologists, non-AFologists, and the AF clinic and the patient actually understands the concepts of managing atrial fibrillation? Well, you can make it very simple. You can make it as simple as A, B, and C. And what do I mean by A, B, and C? This is an ABC pathway, an ABC better care, atrial fibrillation better care pathway. And what is A? A is avoid stroke. A is anticoagulation. A is the steps that I just showed earlier in terms of the stepwise approach to stroke prevention. Step 1, identify low risk. Step 2, stroke prevention or one or more stroke risk factors. Step 3, you make your decision on anticoagulation therapy. What is B? B is better symptom management. Patient-centered, symptom-directed decisions on rate and rhythm control. And what is C? C is the cardiovascular and comorbidity management. You're managing the hypertension, the heart failure, the diabetes, the ischemia, the sleep apnea. There's all the lifestyle things like obesity, exercise, alcohol, and stimulants. There's the patient psychological morbidity that we sometimes as doctors tend to forget. We have to pay attention to all of that. So that's the A and the B and the C. And in fact, this ABC has some resonance with me because in 1996, this book was published, ABC of Atrial Fibrillation. In 2018, this is the ABC of Atrial Fibrillation Management. And how do you operationalize this concept of A, B, and C? Well, as you will see here, this is Atrial Fibrillation Management on one page. And this is something which has now been sent out to our general practitioners in primary care. It is by the so-called West Midlands Academic Health Science Network, which is academics, hospitals, NHS, the GPs. It's also supported by Public Health England, supported by NHS England. It's the primary care, clinical care pathway for atrial fibrillation detected and management. It is a free download. If you do want to get a copy of that, it's not under particular copyright. It's there to spread the word in terms of trying to streamline AF management. And what do you have in this atrial fibrillation on one page? Well, CHADS VAS, has bled, same TTR. What do you have in terms of the management? Avoid stroke, anticoagulation, A. Better symptom management, the B. And the C is the cardiovascular and risk factor management, the C. ABC of atrial fibrillation management. This is one page. You can laminate it, you can stick it up in your surgery. Okay, if that's not simple enough, these days we're in technology, you can have an app. And we did this in China. This is the pilot. The big trial is ongoing at the moment. This is called MAFA for Mobile Atrial Fibrillation App, not Mafia, MAFA. This is the MAFA pilot. It's got risk assessment, it's got educational, it's got and a decision aid, it's got the patient's vital signs, the patient carries their records with them, and then also their follow-up plan. And in the pilot study, which was the first prospective trial of mobile health technology in AF patients, significant improved knowledge, drug adherence, quality of life, and anticoagulation satisfaction. And we're now translating this to an outcome trial based on app-based management, which is running in China at the moment. But it's no point proposing an concept if you don't show it works. So we started a program work to try and look at this. So the first of the outputs was to do a postdoc proof of concept study in a clinical trial population. Now, this was quite an old clinical trial, so it was in a warfarin era. So for the A, we looked at warfarin good control versus poor control, TTR 65, 70% and above versus poor control. Symptoms, we looked in relation to low symptom load versus polysymptomology, so 3 or more symptom attendances. And the C, the cardiovascular component, the ABC component, the C component, we looked at blood pressure target under 140/85 or the use of established cardiovascular prevention drugs like statins, ACE inhibitors, etc. And you will see here, all-cause mortality, composite outcome, first hospitalization, you see the ABC compliant patients in red doing significantly better than the non-ABC compliant patients. And this is the hazard ratios here, all-cause death, 0.35, a 60-odd% advantage in favor of ABC compliant patients. The composite outcome about the same. Stroke was not significantly different. They were all anticoagulated, remember. Look at hospitalizations, significantly lower, about 40-odd% lower. Hospital bed days, significantly lower as well. So you will see the ABC compliant patient translated to less hospitalization, less stay in hospital. And indeed, we looked at the components. This is standard care, which is the reference, but you see AB criterion, BC criterion, AC criterion, ABC criterion. You see hospitalization can be influenced by all of those, but it's only where you have the ABC components where all the hazard ratios are the lowest. And you could almost show a dose-response relationship. On the left is for mortality, on the right is for the composite outcome. Composite outcome is death, bleeding, and cardiovascular hospitalization. So in orange are all the 3 ABC criterion fulfilled. Green is 2, red is 1, 0 is you don't follow ABC compliant at all. And you can see this stepwise relationship of the Kaplan-Meier curves. So the more you use holistic or integrated care, the outcomes are better. So this is the proof of concept study. Postdoc is related to an old trial. So it's always best to test this in an independent cohort. We did this. This was the Atrial AF cohort. This was a prospective cohort in running between 2008 2016, just about 1,000 patients, still on warfarin. These are from Italy. They're very keen on their warfarin. We looked A, again, TTR above 65%. B is by ERA score symptoms. C is optimized cardiovascular outcomes. And you will see the Kaplan-Meier curves here. ABC compliant patients compared to non-ABC compliant, about 60-odd% reduction in adverse outcomes. In fact, that figure is interestingly very similar to the meta-analysis I showed earlier in terms of the outcomes. And you see this is adjusted for multivariate analysis. The ABC pathway management, significantly better outcomes. Now, we did look at the components of the A and the B and the C. You'll see here, no big surprise, you've got good warfarin control, you get significantly better outcome, high TTR above 65 compared to under 65. Now, we also showed that those who are few symptoms do better than those no symptoms. But in some ways you could say this is using the ERA score, but in some ways you could think that's not a big surprise, because in heart failure management, the NYHA, the New York Heart Association score, is prognostic. So we've shown here for the first time how the ERA score is prognostic. And we see here the comorbidity management, and you'll see that the comorbidity were optimally managed, doing significantly better than the poorly managed. And the composite, of course, is the bottom line, 60% advantage with ABC compliant medication compared to non-ABC. So ABC pathway, simple, practical, and then also in terms of dissemination, simple as one page, or you can use an app if you like. And then, of course, in terms of the two proof of concept studies, you can see how it's working. The ongoing app study in China is actually testing the ABC pathway in a cluster randomized trial. Now, the guidelines, it's nice to see how your work gets translated to guidelines. Now, this is the ACCP or CHEST guideline, which is officially published in November, so it's this year. And of course, it's nice to see other people are reading your work, because the Korean guidelines came out as well, and they've got the ABC pathway in there as well. So in terms of trying to optimize the management of atrial fibrillation patients in a simple, practical manner. It is not complicated. It really is simple as ABC. So, colleagues, friends, just to put this all together, in terms of a holistic and integrated approach to risk assessment and management of AF, well, I think it's pretty clear. AF, atrial fibrillation, confers a large healthcare burden from stroke. And in terms of risk assessment, stroke and bleeding risks are dynamic, and regular reassessments are needed. Stroke prevention means oral anticoagulation therapy, whether as vitamin K antagonist with a high time and therapeutic range, or these days increasingly a NOAC. But it's important to recognize the limitations of stroke risk scores, and why they are simplistic, they are reductionist, and really the default should be to offer stroke prevention unless they are low risk. So you avoid stroke, and the A is anticoagulation. You then consider symptom management, and this is regards to the decision on rate and rhythm control. And this should be patient-centered and symptom-directed, better symptom control. And cardiovascular and comorbidity risk factor management is part of the process here, the C in the ABC. And therefore, an integrated care approach, as I've already showed the data from 2 independent studies, significantly lowering clinically relevant outcomes, including mortality, composite outcome, and also hospitalization. So, as the final take-home message, a simple ABC pathway, it does allow holistic and integrated management of AF patients. AF, atrial fibrillation management, should not be complex, should not be considered difficult, should not be any different between primary care, hospital care, and even the patient going away, understanding the way to manage AF. It is really as simple, really as easy as ABC. And with that, thank you for your attention.
Well, thank you, Greg, for an inspiring and most informative inaugural talk here. I can only add that it was authoritative and state-of-the-art. As head of Department of Clinical Medicine, I would like to wrap this inaugural talk up with a few summarizing words. Now, the appointment of you, Greg, as our first distinguished professor to Aalborg University is an important step for our department and for the whole university. Throughout your long career in clinical cardiology and research, you have been at the forefront of matters at all times. More than anybody, you have shaped the contemporary approach to risk assessment and risk management of patients with atrial fibrillation. And in your talk today, you have shared a lot of your insights in that field. You have been as you showed, one of the founding fathers of the current CHATS-VASc risk score, based on real-world data showing the actual risk of stroke among patients with atrial fibrillation. And today you also introduced the ABC score, easy as ABC. Quite simple assessment, yet relying on huge amounts of clinical data. The fine thing is that the CHATS-VASc score can be turned into an easily understandable risk assessment tool. And most importantly, you have been fighting for constant battle to introduce this risk score to clinicians and thereby implementing the CHATS-VAS score on the front line where it actually matters to patients. Easy to understand for the physician, but also to patients. Over the years, you have had a fruitful collaboration with the Aalborg Thrombosis Group, a collaboration that has resulted and been a mutual benefit and has resulted in many joint publications. And also, very importantly, it has resulted in research stays abroad for some of our young investigators. But on a day like this, I think it's also important when you're here for the inauguration of you as a distinguished professor, it's important to look into the future as well. Your professorship at Aalborg University is a mutual commitment to further evolve and expand our collaboration. From your side, it's a commitment to be part of the faculty and help Aalborg University pursue its vision to offer the best medical education in the country, which should be research-based at all times. On our side, it's a commitment to be part of the faculty. It's a commitment to open our doors and seek your cooperation at all times, perhaps not only from a thrombosis perspective, but also from other angles that might result in new research areas. As you well know, Danish registries are a useful source of information, and new angles of exploitation can continuously be uncovered. Tomorrow, we'll therefore have a joint meeting with the Thrombosis Group, but also Professor Søren Jonsen from our new Center for Health Service Analysis, and we will try to explore how to assess quality in the modern health care system. Lastly, I also hope that your position as distinguished professor at Aalborg University can facilitate further internationalization of our research. We, of course, have researchers looking for outbound short and long-term research stays, maybe even clinical training, and I hope that you can be able to facilitate that as well. But at the same time, we hope to attract the best international researchers to come here for inbound research stays here in Aalborg, and you, of course, may also be a catalyzer for that. To wrap up, I'm delighted to receive you here as a distinguished professor in our department. Once again, thank you for the inaugurative talk, and congratulations with the title of Distinguished Professor. I'm convinced that you will make Aalborg University proud of your contributions from that very position. Thank you, Greg.
Thank you, Rich. Thank you for those very kind words. I'm always getting another flush now. It's, as I said, I've been feeling very much part of the family, and it's so nice to be amongst energetic, enthusiastic colleagues. And I think at the end of the day, it's important that we have made, as you can see from some of the things I presented, some of the inroads into improving patient care, changing guidelines, and then, most important of all, having a bit of fun as well. Thank you very much for accepting me as part of the family, and of course, it is my great honor, and I'm certainly feeling extremely humbled by the new title of being the first of the distinguished professors in Aalborg University. Thank you so much again.